Good morning. Today we will try to see what is ADHD. I'll come to the last benches. I'll focus mainly on the last benches. What is ADHD? Hyperkinetic disorder. Very good. Next, anyone else? Told already. 50% he told. So attention deficit. What is H? Hyperactivity disorder. Very good. So a child cannot sit in class, interrupts others, interrupts teachers, interrupts friends, and forgets homework. You even didn't realize that today is psychiatry class also. So what disorder should be suspected? ADHD, because class is on ADHD. So if we see the definition, it is a neurodevelopmental disorder. What is neurodevelopmental disorder? Very good, at least you have tried. So during the development, from the conception to delivery and everything, so it starts during the development of the fetus, development of the embryo. So it is classified as under neurodevelopmental disorders, and it is going to affect the CNS. That's why it is called neuro. There are three core symptoms of ADHD: inattention, hyperactivity, and impulsivity. If you see, the symptoms interfere with functioning and begin before age 18, age 12 I mean. So the first question, a person comes to you, he is 17 years old. 17 years old, the person says, doctor, currently I am having inattention, impulsivity and hyperactivity. Can you diagnose the person as having ADHD? So a person presents to you at the age of 17 with the symptoms of inattention, hyperactivity and impulsivity. Can you diagnose that person or the patient as ADHD? No or yes? No. Yes, the answer is yes. See, the symptoms onset should be before the age of 12. So retrospectively, if the person says that the person used to have these symptoms before the age of 12, then still we can make the diagnosis of ADHD. And we will call it as, if it is after 18, we will call it as adult ADHD. So if we see history, 1902, Sir George Still, he for the first time described hyperactive children. 1937, Charles Bonley, he got that improvement with the stimulants. Then 1960s, for the first time the diagnosis was hyperkinetic disorder. So initially you told attention deficit hyperkinetic disorder. So currently it was not the same classification. So nosology has changed. Okay. So DSM-3 only attention deficit disorder. Currently we are using DSM-5 and it is labeled as attention deficit hyperactivity disorder. So what is the approximate prevalence of ADHD in children? 1%, 5 to 7%, 15% and 25%. So if you see children of around 100 in your OPD, so how many children are you expecting to have ADHD? 5%, 5 to 7%. Next, anyone else? 15%. Any other options? 25. Last option? 1%. So the answer is 5 to 7%. So if you see the epidemiology, around 5 to 7% of children are having ADHD. So the next question comes is, for example, 5 to 7% of children are having ADHD. How many of them will be having ADHD in adulthood? So what is the percentage? Out of 100%, how many of these children will be developing into ADHD? How many of them having remission? That means they are not having ADHD. 10%. So every time you can't be right. 50 to 60, what? Developing ADHD or remission? Almost you are right. That's why I am asking you. 50 to 60% developing ADHD or remission? Remission. See, if you see 5 to 7% of children, 60 to 85% of them becoming adolescents. 60% become adults. In that 40% will be having remission. That means this 5 to 7% children having chances of 60% they are going to have ADHD, 40% they are not going to have ADHD. That means they are going to be in remission. Okay. So boys affected more than girls, it is almost 2 to 9:1 ratio. So boys are almost twice to 9 times likely more than girls to be affected. Strong genetic contribution. and 50 to 60% persist into adulthood. So which neurotransmitter are mainly involved in ADHD? So many of the times we keep this option both A and B. Why not serotonin? धुरंधर का टिकट्स बुक कर रहे हो क्या? अभी तो रिलीज नहीं हुआ है, टिकट्स भी स्टार्ट नहीं हुआ है, मैच भी नहीं है, आईपीएल तो अभी स्टार्ट नहीं होगा, हैं? देखने जाएगा, ठीक है, मेरे लिए भी टिकट काट देना है. So which neurotransmitters are mainly involved in ADHD? You have only options. वो भी नहीं पता है. Norepinephrine. Both. Dopamine. Both. So the answer is both, A and B. So how it is going to affect ADHD children, we will see in the next slide. So in neurobiology of ADHD, if we see children, the neuroanatomy areas that are involved mainly are, first one, hyperactivity. In hyperactivity, the area that is involved is prefrontal motor cortex. So if there is a lesion of or if there is any disturbance in prefrontal motor cortex, there will be hyperactivity. Attention, again, there are two types of attention. One is selective attention and sustained attention. Selective attention in the sense, when you are speaking something, the person has to give that attention to you. For example, I have shown this slide. He don't know, like, there are options for this slide also. So he is not giving that selective attention. Okay. So selective attention, the area involved is dorsal anterior cingulate cortex. For sustained attention, DLPFC. What is DLPFC? This is anatomy only, first year anatomy. Again, he wants to try. What is DLPFC? Huh? You don't know. What is PFC? Prefrontal cortex. What is DL? Very good. Dorsolateral prefrontal cortex. So the area involved in sustained attention is dorsolateral prefrontal cortex. For impulsivity, it is OFC. What is OFC? Occipital frontal cortex. Any others? See, these parts are actually the subdomains or subcategories under prefrontal cortex. So what is OFC? You would like to say? I think you know the answer, that's why you are laughing. What is OFC? The basic anatomy you are forgetting. PFC we commonly use, OFC we commonly use. So impulsivity, orbitofrontal cortex. So neurochemistry, there are two neurotransmitters that are implicated in ADHD. One is norepinephrine, the other one is dopamine. For example, if you want to concentrate in this class, there are two things to be happened. One is the signal, the voice that is coming from my side should be very much audible. That will be taken care by norepinephrine. So it will increase the signal. And the other thing, the friends sitting beside you, they shouldn't disturb you. Okay. So if I am talking very much loudly, but your friend is constantly disturbing, we will book for these tickets, we will go outside, we will have biryani, we will go and get Domino's. So again, you can't hear me. So the dopamine will be going to take care of that thing. So dopamine decreases noise and norepinephrine increases the signal. And regarding Domino's, I have recalled something. Whenever I am trying to put some order in Domino's, now I am not able to get because it is showing it is far. So what should I need to do? Huh? Then I called one of the first year MBBS students. He told me, sir, you have to fake the location. You have to keep the location elsewhere, then you will get, but you have to pay him more. Okay. So, but I am not able to get what location should I need to keep? Arati more. Thank you. So, neurobiology of ADHD, in neuroanatomy, these are the areas that are involved. Hyperactivity, prefrontal motor cortex. Attention, dorsal anterior cingulate cortex, DLPFC. For impulsivity, that is OFC. In neurochemistry, norepinephrine and dopamine. Norepinephrine increases the signal, dopamine is going to decrease noise. Again, which symptom belongs to hyperactivity? Very easy question. Which of the following symptom belongs to hyperactivity? A. Forgetfulness, B. Fidgeting, C. Careless mistakes, and D. Losing books. C. B. Any other options? C. So, most of you are confused between B and C, fidgeting and careless mistakes. So, here the right answer is fidgeting. The careless mistakes comes under inattention. As the person is not able to pay his 100% attention, he is making simple careless mistakes. Okay. Losing books, again inattention. Forgetfulness, again inattention. So, one of the symptom belongs to hyperactivity is fidgeting. So, what are the clinical features? So, clinical features we will be classified under three broad categories: inattention, impulsivity, and hyperactivity. So, inattention. So, person is making careless mistakes, difficulty sustaining attention, easily getting distracted, forgetfulness, and losing things. For hyperactivity, it is mainly fidgeting, cannot stay seated, runs or climbs excessively, and difficulty playing quietly. So, these are the symptoms which are self-explanatory. So, these are the symptoms mainly seen in case of hyperactivity. And impulsivity, so normally even if I ask the question also, many of the times you won't answer, but here the person, even before me completing the question, he blurts the answer. So, that is one characteristic feature of impulsivity. Difficulty waiting turn and interrupts others. So, it happens with cricket, like batting. मुझे batting चाहिए पहले. हर टाइम मुझे बॉलिंग दे रहा है, फील्डिंग दे रहा है, मुझे बैटिंग चाहिए, संजू सैमसन जैसे. ठीक है, लास्ट 3 में उसको मिला है. हाँ, अभिषेक शर्मा. उसका क्या है फिर? So we have to categorize them. So characteristic features you need to remember. For diagnosis, so if a child comes to you, if a child presents to you with the symptoms of ADHD, you can't diagnose, I don't mean like you are diagnosing ADHD, but the patient, the mother or father, they have brought the child with the symptoms which are similar to ADHD. So, can you make the diagnosis as ADHD? So, she will be telling us. Please. Yes. Please. So, for diagnosis, symptoms must present for at least. No, you have to select only one option. So, option A 1 month, 3 months, 6 months and 1 year. B 3 months. So, for a patient who is constantly laughing, do you know which part of the prefrontal cortex is involved? Before that, you have to know what is the context, why you are laughing. So, something is going here. Sit down. So, for diagnosis, you can't diagnose any child who is present with normal hyperactivity. So, we will see them in differential diagnosis. So, these symptoms must present at least for 6 months. Then only we can diagnose the case as ADHD. Again, I will make you stand up if you constantly laugh. Okay. So, DSM-5 Diagnostic Criteria. So, in DSM-5, there are 2 components, A and B. In A, it has given hyperactivity or inattention and impulsivity. The other one is hyperactivity. So, in A there are 9 symptoms and B there are 9 symptoms. So, out of 9, the child should be having more than or equal to 6 symptoms of inattention or impulsivity and or hyperactivity. And these symptoms should persist for at least more than 6 months. And onset before age 12, as I have already mentioned, but you can still make the diagnosis in the adult patients if they have retrospective recalling of these symptoms in their childhood. Presented more than or equal to 2 seconds. So, if a child is constantly creating disturbance only at home, are only constantly having these symptoms only at home, you can't make the diagnosis of ADHD. These symptoms must be present in at least 2 settings. What are those 2 settings? Friends, playground. So in these 3, at least out of 2 situations or 2 contexts, the child should be having these symptoms. Then only you can make the diagnosis of ADHD. And this should cause functional impairment, either academic achievement, poor academic achievement, or poor grades in the class, not able to have good social relationship with his friends. So they should cause functional impairment. So this is the DSM-5 Diagnostic Criteria. So there are 9 plus 9 symptoms: inattention, impulsivity, and hyperactivity. Out of 9, at least the child should have 6 symptoms in order to make the diagnosis of ADHD. Should be more than for 6 months, present in 2 settings, and they should cause functional impairment. And onset of symptoms should be before age of 12 years. Investigations. ADHD is always a clinical diagnosis. There are no specific investigations. There are no radiological imaging. There are no biomarkers directly to give the diagnosis of ADHD. So ADHD is a clinical diagnosis. It requires repeated history. It requires corroboration from parents, corroborative history from teachers, corroborative history from friends or siblings, clinical interview, parent or teacher reports. Then some scales are used. Screening scales, diagnostic scales. Few scales includes Vanderbilt, Connors ADHD rating scale, then adult ADHD rating scale, multiple scales, and learning assessment if required. So maybe many of the times what happens, the child is having IDD, intellectual disability disorder. Maybe that is the reason why the child is not able to pay attention to the classes. Maybe that is what we misunderstood as ADHD. So you have to rule out whether it is due to IDD or the symptoms of IDD is secondary to ADHD. As the child is not able to focus or child not able to pay attention, the child is having difficulty in learning, child is having difficulty in getting grades. So you have to rule out those things. So investigations, there are no clear-cut investigations, blood or radiological investigations. So basically it is a clinical interview, parent or teachers reports, few scales are utilized, then learning assessment if required. So which is the most common comorbidity with ADHD? Just pick one option. B, schizophrenia. Okay, next. This time we will ask first benches. What is the most common comorbidity with ADHD? Bipolar. Schizophrenia, and the other one is bipolar. Other options? Maybe she's feeling sleepy also. So bipolar. So most common comorbidities, the first common comorbidity includes ODD, that is oppositional defiant disorder. What is oppositional defiant disorder? Anyone know? So oppositional defiant disorder is something. So basically oppositional defiant disorder and conduct disorder are the 2 categories. One is severe, that is conduct, the other one is oppositional defiant disorder. Oppositional defiant disorder, there are 3 things like argumentativeness. So whenever there is some scenario, the child or the patient constantly involves in arguing with elders. Then vindictiveness, that revengeful activity. So whenever someone has done something to the child wants to take that revenge and always will be in the irritable mood. But in conduct disorder, always violating the rights of others, and theft, stealing things, these things. So comorbidities, most common will be ODD, then second will be conduct disorder. Following that, secondary to ADHD, the child can have learning disorders, anxiety disorders, depression, and autism spectrum disorders. Can you diagnose both ADHD and ASD in the same patient? The child is having ADHD and you also confused about the symptoms of ASD, that is autism spectrum disorder. Can you make both the diagnosis in the same child? No or yes? You said no. The answer is yes. So according to DSM-5, you can make both the diagnosis in the same child, ADHD and ASD. So what are the differential diagnoses? So before the differential diagnosis, whenever the child presents to you with ADHD symptoms, what is the first differential diagnosis that you will encounter? So if a child presents to you with ADHD symptoms, The parents has brought the child. Parents told, see doctor, my daughter is having trouble in listening to the classes. She can't sit at one place for a long time. She constantly fidgeting. She makes the careless mistakes. Whenever I gave her any task, she was not able to fulfill that task. So will you be able to make the diagnosis of ADHD? So what is the first differential diagnosis that comes into your mind? Maybe the child is normal. So always in psychiatry, you have to see whether the child is normal or abnormal first. Maybe that is the normal hyperactivity of the child. Okay, so the normal high activity or hyperactivity has to be taken care before making any diagnosis. Then anxiety disorders. In anxiety disorders, the child can't give much attention to whatever being taught. That can be misdiagnosed as inattention. So anxiety disorders. Mood disorders, for example, bipolar, if the child is in mania, so again the symptoms will be resembling to impulsivity. Learning disability and sleep disorders. What are the learning disabilities you know? Learning disabilities you know in psychiatry. SLDs, specific learning disorders or specific learning disabilities. Dyslexia, very good. Then, what is dyslexia? What is dyslexia? No, only reading, not writing. So what do you call a problem in writing? Difficulty in writing? Dysgraphia. Agraphia is completely lack. Then what is the problem, difficulty with mathematics? Dyscalculia. Okay. So apart from these three, using your common sense, tell me which is more common in females? Dyslexia, dysgraphia and dyscalculia. Dyscalculia, very good. Other two disorders are more common in males when compared to females. So differential diagnosis, whenever you are going to diagnose any psychiatric disorder, you have to see whether it is normal to the child, whether it is normal to the adult, you have to see. Then only you can go for the other diagnosis. Now, first line medication for ADHD. Last 2 to 3 slides. First line medication for ADHD. Options are there. Methylphenidate. Any other options? First line medication for ADHD. Haloperidol, methylphenidate, diazepam and lithium. So haloperidol is the first line medication for what? You can go for psychosis or schizophrenia, but still nowadays we go for olanzapine, second generation antipsychotics. Then diazepam is first line medication for what? In psychiatry we are talking. Of course in seizure it is not the first line medication. Can be insomnia, but more often I am expecting an answer that is alcohol withdrawal. Diazepam is the first line medication in case of alcohol withdrawal. If the patient presents to you with the withdrawal symptoms, then the first medication of choice will be neglecting first and second benches, that's why they are constantly talking. So lithium is the drug of choice for which medical disorder? Bipolar, which disorder? Bipolar, how many bipolar types you know? So first line medication for ADHD is, what is the option for this question? B. What is B? Methylphenidate comes under which class of medications? CNS, very good. CNS? Stimulants, very good. So CNS stimulants, methylphenidate. So always in every psychiatric class I used to teach you, management of psychiatric disorders is not itself pharmacological basis. Just giving medications is not sufficient for the patient. So initially the non-pharmacological management, which includes psychoeducation. So how you are going to psychoeducate the parent? How you are going to psychoeducate the parent? You are, the parent brought the child with the symptoms of ADHD. So how you are going to psychoeducate? So what are the things that comes under psychoeducation? Please, the parent has brought the child with the symptoms similar to ADHD or resembling to the ADHD. So in psychoeducation part, so how you are going to psychoeducate the child. For example, in malaria, you will say these are the symptoms, these are the aggressive things, so these are the aggressive things, so you have to act accordingly. What are the food to be taken, what are food not to be taken, so these are the things that you are going to say. In psychoeducation of ADHD, what are the things that you are going to advise? So what are the things that you will do in counseling? How will you tell a parent that your child is having ADHD? Giving love. So psychoeducation is one of the most important things in psychiatry. For any disorder, before going for pharmacological and non-pharmacological management, you have to give the psychoeducation. Psychoeducation involves revealing the diagnosis. So the name of the diagnosis should be known to the family members. What is the course and prognosis of the this disorder? What are the treatment options available for this disorder? So these are the things that to be told to the family members. So psychoeducation involves revealing that disorder, then revealing the course and prognosis, revealing the treatment, everything. Then coming to behavior therapy. In behavior therapy, there are multiple behavior therapies that are used for in ADHD. We will focus on classroom interventions. A child has presented to you. The mother says he was not able to concentrate even 5 minutes in the class. So what are the interventions that you are going to tell the mother? Stand up. So please silence. So we will listen what he speaks. See that aura you are getting from your class. So in classroom interventions, so I have given the example. A child presents to you with these following symptoms: ADHD, impulsivity, not able to sit at one place for a long time. So what are the advices you are going to give to the teacher to make the child sit at one place? So but he can't concentrate on the class. He will constantly play with that toy. Now child is sitting in the classroom. So you have to make the child sit and listen to this class. The first thing that I am doing here, asking questions to everyone. Asking questions to the ADHD child so that he won't deviate from what he is currently. This is one thing. Second thing is you can take breaks for that ADHD child. For example, after 15 to 20 minutes, you can ask the child to bring duster from the other classroom. You can go and you can have water. So that breaks makes the child to concentrate in the class. Parent training is very important. How to manage that child. These things are very important, and social skills training. In ADHD children, the main lacking point is social skills, because the child can't concentrate in the class, the child can't concentrate with the friends. So he is having difficulty with friendship also, in developing and maintaining friendships. So management in case of pharmacological, first line will be stimulants, methylphenidate and amphetamines, and non-stimulants include atomoxetine, venlafaxine and clonidine. So methylphenidate is stimulant and amphetamine is stimulant. Amphetamines are currently not available in India. So methylphenidate is the drug of choice for any child present with ADHD. Of course, if the child is having other problems, we can go for non-stimulants including atomoxetine or clonidine. Venlafaxine is not available. So conclusion, ADHD is a common neurodevelopmental disorder. Early diagnosis improves outcome. Multimodal treatment is most effective.